Okay, perfect. Well, good morning, everybody, and thank you for joining us on our monthly Bench with Bedside webinar series. Many of you are participants in our research study that is aimed at studying breast cancer survivorship in a multifaceted manner with molecular markers of minimal residual disease and social determinants of health. And I keep saying this, and we are sort of teeing it up for you so that we can present updates on our study in the coming webinars, and just be on the lookout also for email updates on this as like there's been lots of progress, and we want to share our progress with you. But it's my real pleasure today to introduce our speaker, Dr. Kimberly Miller, who is an associate professor in the Department of Population and Public Health Sciences at the Keck School of Medicine of USC, which is where I work as well. So we are colleagues, and it's been a pleasure getting to know Kim over the last few years. Her research focuses on understanding the health behaviors, healthcare engagement, and quality of life of children, adolescent, and young adult cancer survivors. She is currently the principal investigator of 2 National Cancer Institute R01-funded studies in this area, which is really a giant feat, and it's a very impressive resume to be able to have 2 R01-funded studies at the same time. So she's really going to bring a lot of expertise to us today. Her research incorporates behavioral, epidemiological, and implementation science methodologies to inform clinical practice and policies to develop appropriate care delivery models in order to also help reduce disparities and to help improve the overall outcomes for populations that are at risk. She is a founding co-director of the Center for Young Adult Cancer Survivorship Research, which is an interdisciplinary research collaborative that's housed at the USC Norris Comprehensive Cancer Center at the University of California, and also the Irvine Chao Family Comprehensive Cancer Center and MD Anderson Cancer Center. And together, their mission is to study and improve the health and outcomes of young adult cancer survivors. But she's going to bring some personal touches to the webinar series today and talk about not only her collective knowledge and expertise in this area, but also she's going to bring her own personal perspective and story to it. And I think it'll be valuable for all of us to listen to her today. And again, thank you all for joining, but also thank you, Dr. Miller, for being here today.
Thank you so much, Dr. Salia. I'm so happy and privileged to be here. I am going to share my screen now, if it's okay, and start my presentation. So hopefully everyone can see this. Can everyone see? We're good? Okay. First of all, thank you all for coming here on a Saturday morning on Labor Day weekend. I'm hoping that I'm going to not bore anyone because I designed this to be storytelling, because, you know, Saturday mornings, right? I'm not going to have a lot of charts and graphs and data. And it's funny because when I was, when the organizers, when Bodor and Audrey and Diana reached out to me to do this, I originally said, well, I don't really work on breast cancer. I'm not, I'm not a breast cancer researcher. And they said, that's okay. It's relevant to what we do. And I said, oh, I accepted. I was honored to be asked. And then it occurred to me, what a strange thing to say, considering my own family history of genetic breast cancer. I had never really made the connection between my past and my family experience and what I do. It never occurred to me that potentially what I do or my family's history informs where I am. So that's what I'm going to talk about today. So let me talk to you briefly, even though Dr. Salia did a great job of describing the research that I do. I work on young adult cancer survivorship, and that population is generally defined as diagnosed under age 40. It's actually 2 subpopulations. It's pediatric cancer survivors who are diagnosed under age 20, and then what we call AYAs, adolescent and young adults, who by National Cancer Institute are defined as 15 to 39. So you're considered young if you're under the age of 40 and you are diagnosed with cancer. It's not to say that people at all ages who are diagnosed with cancer don't have significant issues. A cancer diagnosis always impacts one's life, typically negatively. But for young adult survivors, it's a unique and distinct population due to their age and life stage. They have distinct medical and psychosocial issues. And a spectrum of challenges. And here you can see some of the life disruptions that young adults have, even if they're pediatric and they grow into young adulthood, or if they're diagnosed within this, this period of time. At this age, if you think, if you're at this age, or if you're older, if you're like me in middle age, and you think back to what you were doing when you were young, this is a time of identity formation. It's a time of where you're initiating, you're launching into your life. You may be partnering, forming, romantic relationships. You're consolidating your social relationships. You're maybe starting your schooling, college or vocational school, or starting your job and your career. And you also, you may, when you're diagnosed, it's rare in young adults, you may be the only person who has had cancer. So cancer at this age presents unique issues. And specifically what I study is quality of life for young adult cancer survivors, across the spectrum of psychological and social impacts, physical impacts, but also their access to care. In Los Angeles, in Southern California, we have a large medically underserved patient population. And so a lot of what I do is looking at factors related to the financial and material hardship that young adult cancer survivors have, and how that can really serve as a barrier to them getting the kind of follow-up cancer care that they need. We have very high cure rates for this population. That's the good news. The bad news is that because there's many life years left to live, they often have long-term effects, not just from cancer, but from the treatments they get from chemotherapy and radiation and targeted therapies. And so they need to be able to stay in care, and they often drop out. So that's just a little overview of the work that I do. But really, I'm here to talk more personally about my own story, which I never connected to being a researcher. And I have never talked about it publicly. It's not something I hide at all. It's just that most of the time when I'm giving talks, I'm talking about data and my own, my research, not my own story. So I'm going to talk to you a little bit about origin stories. And where does that phrase come from? Where did I get that? Well, it comes from, for me, superheroes, because when I was a kid growing up in Baltimore, Maryland, I was really into comic books, all like types of comic books, like Archie comic books, but also, superheroes, Marvel and DC Comics. And the thing that I was really fascinated by it more than anything was how they got their superpowers, their origin stories. So, for example, we can take, I'm not going to extensively walk you through each of these ones, but, just maybe this, but Spider-Man, his name is Peter Parker, and he was a teen growing up with his aunt and uncle, very scientifically, smart. And he was at a science exhibit and was bit by a radioactive spider. And that's what gave him his superpowers, which are agility and athleticism. And he can climb walls and adhere to things. You may know that he shoots webs from his wrists. That's not actually a power. That's something because he's so smart he developed. But anyway, that's how he got his superpower. Wonder Woman is different. She actually is from a race of Amazons, and her mother, if maybe you saw the movie, I actually didn't see the movie, but her classic story is her mother created her out of clay, and then she was given life, and the Greek gods gave her her superpower. So she's from this race of Amazons, and that's why she has a kind of Grecian, sexy Greek looking thing to her. But I think the superhero who most puzzled me and fascinated me was Batman, because he doesn't actually have superpowers. I mean, what happened to Batman is he witnessed his parents being murdered when he was very young, during a mugging, and it traumatized him. And so he dedicated his life to crime fighting and became very wealthy through his business operations. And so he can pay people to create all these gadgets for him and things that allow him to like fight crime. He doesn't have superpowers. The Bat persona, I never understood. There's different stories for it, but that always really puzzled me about him. So let me be clear. I'm not saying I'm a superhero, and I'm not putting too fine a metaphor on here. What I am saying is that I think one of the reasons why I was fascinated by this is because when you're young, you like to think, where am I from and where am I going? And am I destined for greatness? Right? And I'll tell you that by any measure, if you looked at my grades through kindergarten all the way through high school, I was not destined for greatness. I was destined for mediocrity. And I often got in trouble because I was kind of, a big mouth in school. And, I was getting notes home all the time. So I was not going to be Wonder Woman anytime soon. And I think part of that is because of my family dynamic. So I am from a large Ashkenazi Jewish family who emigrated from Lithuania and Latvia. So Ashkenazi Jews are European Jews from, Central, Northern, and Eastern Europe. And if you look up, if you do what I do and you Google Ashkenazi Jews stock images, you get pictures like this. And it's like this happy family. This is, it's Hanukkah, it's the last night, he's with granddad, his Zaidi, he's lighting the last candle. They're all really happy. And there's lots of these different images of these happy Jewish families. My family was not necessarily like that. We were more on the line of kind of the Larry David model of family. In fact, we were what you call a high conflict family. So, for example, we had a lot of political differences. Half the family was very like, politically one way, and half the family was politically the other way. We differed on issues regarding Israel and the Middle East. If a big movie came out, half the family loved it and the other half the family hated it, and everything had to be sorted out over food, with people screaming at high volume. And I say that with lots of love, but definitely my family was not the stock images. We were much more in the Larry David camp. This is my actual family, though. We would get together, my extended family, most of whom lived in Baltimore, some in Philadelphia, some in Richmond. But we would get together for holidays, and we would get together every Sunday and have Sunday brunch, big Jewish Sunday brunch with like bagel and lox and whitefish. And if you were a kid growing up, I don't know if people still do this, but if you were a kid growing up in the East Coast and you were Jewish, that was very typical. And so let me see if I can use my little laser pointer. Here is me. I'm playing with my braces, I think. That's why my hand's in my mouth. That's my dad and that's my mom. And the rest are, aunts and uncles and extended family members and my cousins. So my grandmother, I'm going to talk about my grandmother because she played a central part in this story and in my life. My grandmother, she was from Lithuania, and she was from this really small town. I can't even pronounce it. It's called Pumpkin in Yiddish, and it's really like shtetl country. Like it's, very much, I think there was, I don't know, like 1,000 or 1,500 inhabitants. And there she is. This is an amazing photo of my grandmother and my aunt, and there she is in later life. She didn't speak English. She only spoke Yiddish. And so the older people in my family spoke Yiddish together. I didn't speak Yiddish and I didn't understand. And in fact, I thought for a long time that Yiddish was a language that adults spoke. That was adult. And then I realized, oh no, it's actually a totally different language and not everybody speaks that language when I went out in the world. But my grandmother and I saw her every Sunday and we had a close relationship, as one can have when you don't speak the same language. You know, she would give me food, we would watch TV, she would hug me, she would kiss me. Um, but when my family didn't want the younger people to understand what they were talking about, they would speak Yiddish. And she didn't really like talking much about her background, and that we didn't know very much about her. One thing we knew was that she had 6 sisters, and she was the only one who left. My family emigrated between the pogroms of Stalin and Hitler, and she was the only one who was able to make it out of Lithuania. Um, and so she never knew what happened to her sisters. They, most likely perished. But one of them had died when she was young, and her mother had died when she was young. And that was something that we knew was very sad and traumatizing for her. And it led her to her, obsession with the evil eye. And this is not uncommon in many, not just Jewish cultures, but in many folk cultures, right? So the evil eye is like a folk peasant culture, but in Ashkenazi Jewish culture, especially people of that generation, it's definitely was a superstition that was alive in my family. And so the Talmud, which is like the central rabbinical text for Jews, has this quote, which is, I think it's kind of funny. It's 99 of 100 people die prematurely of the evil eye, while only one dies by the ways of the world. So according to the Talmud, okay, 99% of people die of the evil eye. So my grandmother had cause to be worried about it. But she taught me protections. There are things you can do to protect yourself against the evil eye. I'll share them all with you. One is to spit 3 times if you hear something bad or misfortune happens. You don't have to physically spit, you just make like a little like sound. Another one is pinch your ears, especially when you sneeze, but pinching your ears if you hear something bad, that can protect you. Wear an amulet, sort of like the one that I'm showing over here, or say Kinahora like 500 times a day, which is what she ended up doing. Kinahora is Yiddish. It comes from, Yiddish is German and Hebrew. So Kain is Yiddish and Ayin Hara is Hebrew, and it means literally no evil eye. So my grandmother, she would say a lot, she would say Kinahora to me all the time and to my other family members to protect us. But it was also kind of known in my family, or the idea was that we had misfortune, we had illness, we had worse luck than most people. And younger members of my family would laugh and say things like, no, that's just being Jewish, grandma. Like it was just, it's just our bad luck, right? Jewish humor. But let me tell you a little bit more about my family. You can probably see where I'm going here, but this is just my paternal family in the late 1970s, and there is me. But my grandfather, he was much older than my grandmother, and he passed away before I was born, so I never knew him. My grandmother had 3 children. My dad, so here the squares mean that they're male and circles mean that they're female. And if there's a line, it means that they've passed away. So my grandparents had 3 children, my dad, my uncle, and my aunt. They in turn had my cousins. This is fraternal twins here. So you can see what's interesting is my dad was the youngest by far. So I'm on this kind of lineage with my first cousins, but I'm at least 20 years younger than 20 to 25 than all of these cousins. And so my first cousins felt more like aunts and uncles to me. And then I was pretty much the same age, maybe a few years older than this generation of cousins below. So this is what we look like in the 1970s. And then cut to the 1990s. So by this time, my grandmother had passed away. And what happened then was my cousin, my female cousin, my aunt's daughter, was diagnosed with breast cancer. At this time, I was in college, and of course, my family's communicating and calling, and I was in DC, and she was in Baltimore. And everybody was talking and heard that she had been diagnosed with breast cancer. And so I immediately got on the train and I went to Baltimore to go visit her and try to help her. Unfortunately, her breast cancer was early stage and it seemed like she had a good prognosis. She had by this time had 2 kids. But what she was very upset. And the reason why she was upset about this is that she had found out during her breast cancer that my aunt also had breast cancer when she was younger, but never told anyone. Now, someone knew in my family, okay? Somebody in this generation must have known. Certainly her husband did, but she never spoke about it. We found out when my younger cousin, the one on my age, not my age group, but my lineage group here, we only found out about it because she had breast cancer. And my aunt said, well, I didn't want to trouble people. There was stigma, there was superstition. She didn't want to talk about it. But then, weirdly, what then happened was my other cousin developed breast cancer about a year later. And this cousin here was kind of a rabble rouser, kind of a muckraker. And she was like, what's going on here? Why is no one talking about the fact that, our aunt had breast cancer? And then she started digging into history because she found out that it was probable that my grandmother also had had breast cancer. Now, she wasn't able to get medical records, but she was able to not confirm it, but she did all sorts of research and talked to family members and extended family members. And she ascertained that my grandmother likely had breast cancer. So this generation had cancer and never talked about it, but then it started to develop in this generation. Now, my cousin, interestingly enough, this cousin was diagnosed in the late 1990s, and she lived in Philadelphia. So she went to get genetically tested for her breast cancer, which was something that this cousin and my grandmother, of course, never had. So after she was tested, my cousin called me and she said, we need to get together. I didn't know she was tested. She just called me and said, we need to get together. We need to talk. And I said, well, we can talk now. We're on the phone. She said, no, it needs to be in person. So I knew something bad was going to happen because when your cousin says, I can't talk to you over the phone, you need to take a train up to Philadelphia from DC, it was probably bad news. And I thought what she was going to tell me was that her cancer had progressed or advanced. But she said, I went up to Philly and I talked with her and we sat down and she said, my breast cancer is genetic. It's in our family and you need to get tested for it. So that was how I found out that my cousin was positive for what some people call BRCA, BRCA2. So what is BRCA? Most of you probably know, but it's a gene. And we all have a copy. We all have 2 copies that we inherit from our parents. And it is a gene that produces a protein that repairs DNA. So if you have a faulty or a variant or a mutation, it's not doing its job of repair, and it puts you at higher risk of cancer. And notably, especially for females, breast and ovarian cancer. Although there's all other types of cancer that are related with BRCA1 and 2, and then males also get it: prostate cancer, pancreatic cancer, melanoma. But interestingly, so BRCA was not found, it was not discovered or isolated until 1994. And then that was followed by the discovery of BRCA2 in 1995. And in 1996, it became the first genetic cancer screening in clinical practice. And it was done at the University of Pennsylvania. They were the first to offer genetic testing in the United States. That's where my cousin was. She was living in Philadelphia. And so she went to University of Pennsylvania. So she was an early adopter of genetic testing. And that's how we found out in the late 1990s, which is very early. So BRCA is for culturally and geographically distinct people, like Ashkenazi Jews, they have something called founder mutations. And that is, you can trace it back to a small number of people. It's distinct, right? So Ashkenazis have 3 of these founder mutations. Icelandic people have a specific BRCA mutation. Norwegians, there are other people that have these founder mutations. But Ashkenazis have the highest rates. And so Ashkenazi Jews have a 1 in 40 chance of carrying a mutation in their BRCA gene, which is 10 times higher than that of non-Jews. And it wasn't until 2005 that guidelines for genetic testing for BRCA were issued. So you can imagine that in the late 90s, in the early 2000s, when this was happening with my family, there was a lot of unknowns and, insurance didn't cover it. And, the landscape of BRCA was not what it is now. It was very different, and you didn't necessarily know what to do. So here I am in the early 2000s. I've been told that I need to get tested. That's a terrible photo, but it's me in New York. And my whole vibe is I live in New York in Greenwich Village and I'm loving life. I'm wearing a leather jacket and I'm super cool. Okay. But I also know that I need to get tested. And I've talked to my family, and we do what we always do, which is get together and have a high conflict session over food about genetic testing. And as it turned out, nobody wanted to get tested. The women were being tested, because at this point, men were not being tested. No one wanted to get tested except for me and my little cousin, the daughter of my rabble-rousing cousin who had breast cancer. And so we decided to go together, and we decided that we were going to go to Memorial Sloan Kettering, MSK. And the reason why is because by this time, my cousin's cancer had advanced, and she had switched her care to Memorial Sloan Kettering in New York because she was on a clinical trial, and MSK was known for being aggressive. And it was kind of her last chance. So she arranged for us and paid for us, because I don't remember arranging it and I don't remember paying for it, but we went to have genetic counseling. And the interesting thing was I was terrified. I went with my cousin for the counseling, and then we both were tested. And I was incredibly scared going into the cancer center, going into the genetic counseling room, even though I have my little cousin with me and I was close with her. But the genetic counselor immediately, it's hard to explain, but immediately I felt in good hands with her. And she said, I know it's hard and I know you're scared. And she validated that. And she said, but there's a lot we know now, and there are things that we can do. And she went through with us and did a counseling session and talked about what would happen if we were found to be positive for BRCA, and gave us guidance and advice. And I remember she gave us her phone number and she said, call me at any time. And if it's after hours, you can page me. And I walked out and I felt something lift from me. And, for lack of a better word, I felt kind of empowered. I mean, I was still extremely frightened and scared, but, there's something about going from not knowing to knowing that is really powerful and very, very helpful. And so we proceeded with the genetic tests. And I'll tell you that if that counselor hadn't been who she was, I may not have gone through with the testing itself. And if I had gone through with it, I may not have gotten the results, but I trusted her and I trusted that I was in good hands. I don't know how long it took, but it took a long time to get the phone call that told me that I was not positive for the gene mutation. And I felt immediate relief. But I then got a phone call from my younger cousin who told me that she was positive for BRCA2. And so it wasn't the kind of thing where I was going to go out and pop the champagne cork, because my focus immediately turned to feeling guilty and feeling worried about my cousins and my other cousins. I was also told by the genetic counselor that I wasn't scot-free, that I needed to continue genetic counseling and I needed to get probably rescreened because this was emerging and evolving. And that it probably made sense for me to go on to a high risk protocol. Not as high risk as my cousin who was positive. So 1 month after my young cousin found out that she was BRCA2 positive, her mother, my older cousin, passed away from cancer. So she had a lot on her plate. And it really, at that point, I think my entire family was in great chaos and conflict. We lost our cousin. Younger cousin was positive, and other people weren't really testing. And my cousin was 22, my younger cousin. She'd lost her mom. She was grieving for that. And she also knew that she had to make some quick decisions in her life. So this is what my family looks like today. And this is who has had breast or prostate cancer and who has passed away. And you can see now that we have had kids in this, and I have a kid. But this is what pedigrees look like for BRCA. And essentially, the good news is that all of us, I think, in this generation have now tested and know what our status is and feel comfortable discussing it and understanding it and discussing it with our children. But it took a long time. It took years for us to get to that point where everyone kind of adopted the mindset that we needed to test and protect ourselves. So that's the end of part one. That's my BRCA family history. Strangely, I never connected that with my current research, my current role as a cancer researcher. It was always just my personal history. It really had nothing to do with what I did. I only began thinking about it when I was asked to give this talk, which is really odd, right? Not that I'm very, I talk about my genetic cancer, my family's history often, just not professionally. It's not part of my professional. So in 2008, I had then moved to Los Angeles. By this time I had a kid and I was married, and I was working as a grant writer in nonprofits, and I thought, I really want to go into health in some way. And I was incredibly interested at that time in infectious disease and food safety. I don't know why. I wanted to be a food inspector and give like the grades at the restaurants. That's what I wanted to do. And that's why I started my master's in public health at USC in 2008 to become a food inspector. But of course, the minute I hit USC, I walked into Norris Comprehensive Cancer Center and I was like, no, this is what I want to do. It felt like going home. It's really weird. Even looking at this picture, it feels like a second home to me because I've been at Norris and at USC since 2008. So I immediately got a job there. And my job was recruiting and interviewing melanoma patients. And I felt more satisfied and fulfilled with that work than I ever had in my entire life. And I knew that's what I wanted to do. So I finished my master's and then I went immediately into my PhD studies in what was then called the Department of Preventive Medicine, and I continued working on melanoma. I wrote my dissertation on a skin cancer prevention intervention we did in Los Angeles Unified and Pasadena Unified to show the effectiveness of this trial. And that, I continued to work in that disease focus, and it's still a part of my research is melanoma. I stayed at USC and completed my postdoc here. And the reason I did is because of the cancer environment. It's so rich. We have an incredible, you know, clinical architecture, incredible clinicians, incredible resources. And, you know, growing up at USC with cancer research, I mean, it's one of the things we do best. And so why would I leave? So I stayed at USC and I joined the USC faculty in 2017 as a full-fledged cancer researcher. I submitted my first R01 on Monday. My R01 grants are major grants from National Cancer Institute. I remember it very clearly because Monday, March 16th, 2020 was the first day of remote work. Really weird to have a grant due because that Friday we all left, we all packed up our offices, left USC, did not come back for, you know, at least a year because the stay-at-home order in California was issued on the 19th. But I got my grant in remotely, and that grant was awarded in 2021, and that's my social health study in young adults, which takes place now at Norris Comprehensive Cancer Center, Keck, and also Los Angeles General. I'm recruiting young adult cancer survivors and seeing how a cancer diagnosis affects their social relationships. That is one of my current grants that Bodor spoke about. So, you know, in reflection, when I think about what I lost as a result of having genetic breast cancer in my family, not being BRCA positive, but of course I lost family members. I lost a lot of family members, but I also lost, as a younger person, that sense of invulnerability, right? I had that, and as soon as my cousin said to me, you need to get screened, that's when I lost that. And I also lost that sense of an endless horizon. You know, when you're young, you think, I have an endless life to live in front of me. But you realize when you have young, you know, people in your family who pass away of any reason that you may not have that endless horizon. And when you are in a context of, you know, genetic cancer, it really sort of hits home. But I also gained things. I gained a stronger sense of my family. We are still a high conflict family. I'm not gonna lie, but we're close. And also a sense of community identity. And by that, I mean, not just with, you know, Ashkenazi Jews, although, you know, there's many advocacy organizations that my family strongly, you know, is a big part of with genetic testing for Ashkenazi Jews, but also a sense of community within the cancer world, you know, like people who are survivors, but also survivors adjacent, caretakers, family members, siblings. That's my community. I have a profound gratitude to clinicians who have taken care of my family members, who take care of cancer patients, and also the genetic counselor who was understanding and validating and empowering for me. I have an acceptance of death as a part of life, but it's also important that I recognize that when one is dying, they're still living. You know, that they're still part of the world. They still have things that they are doing and taking care of. And that has, I think, informed my work very much. In ways, for example, of including metastatic patients, patients at end of life in studies. They still have so much to contribute. But strangely, I also recognize my own privilege and my fortune, my good fortune. Why am I privileged and fortunate if I have had genetic breast cancer in my family? It's because we had means. We were a white middle-class family with education and enough financial means to have genetic testing and then take steps we needed to reduce our risk of cancer. That's not true for all women. So there are tremendous cancer disparities in women of color with breast cancer and with genetic breast cancer. So African American and Hispanic Latinx women, for example, have much less representation in genetic research they have less information and awareness about genetic cancer, not just BRCA, but all genetic cancers that may affect them. Less access to genetic testing and far lower rates of adoption of genetic testing than white women. I read one study that found that African American women are 16 times less likely with breast cancer than white women do have genetic testing, and that Latinas are, twice less likely than white women to have genetic testing. There's also experience of healthcare and discrimination and bias that women of color experience that lead them to have medical mistrust and maybe not adopt genetic testing, or maybe misperceptions by clinical folks and personnel that these women are not at risk and do not offer genetic testing, or make decisions about their ability to pay or not pay, or to be insured or not insured. And it's not surprising, given all of these factors together, that women of color have higher breast cancer mortality. They have worse outcomes. So in my family, even though several members of my family died of breast cancer, we had many opportunities, much fortune, and much privilege. And that is something I carry with me, and something that has informed all of the research that I do, understanding how lucky we were in many ways. So what I carry forward into my research from my experience is the need to support patients, previvors, survivors, and their families, and to support them in ways that, again, provide knowledge, clarity, shared decision-making, empowerment. It's something I benefited from, and something I witnessed my family benefiting from. And every patient and survivor should be able to have that same experience. And relatedly, to ensure good healthcare experience that meets the needs of patient survivors and their families. That is to say, to be heard, to be met where they're at, to feel that they have autonomy over the decisions that they can make, and to be free of bias and discrimination. And also clear, actionable healthcare pathways, because if you are genetically tested, what do you do next? Everyone deserves to know what the next steps are, to be supported in those next steps, and to be able to figure out ways to have that covered, and to be able to afford those next steps. That's, equitable healthcare. And I know that my ex-doctoral student, Julia, is on this call, and I've learned this actionable healthcare pathways phrase from her, because she does a lot of work in fertility impairment after cancer. And it's similar with fertility counseling. If cancer impairs your fertility, you need a plan, right? This is just basic cancer equity. So even though I don't work in genetic cancer, it has understanding that patients need an actionable path forward when they have information, and they need to be supported, and that needs to be equitably distributed, is what I carry forward as part of my experience. And so now here I am. I run a center. This is some of my team at a conference, a young adult conference. I run a center for young adult cancer survivors research at USC, at UCI, at MD Anderson. Have an amazing team, and I have incredible colleagues, and I have opportunities that are really unmatched, including things like being able to talk to all of you on a Saturday morning about my own personal experience. And so with that, I will say thank you so much, and open it up to any questions.
Wow, thank you for that, Kim. That was just so profound and so compelling. And thank you for walking us through your story. I think you could probably tell, like, we usually have people dropping out, like we had your full attention, like, or you had our full attention for every single minute of your talk. So thank you for that. That was fantastic. And yeah, let's just open it up and please, please ask questions. We can have a discussion from this point. So anybody have questions to start? I think Lisa, are you coming on?
Yeah, can you hear me?
Yeah, we can hear you.
I don't know how I guess I didn't activate my video, sorry. But I just wanted to mention, well, I had breast cancer in 2018, and at the time I was on Medicare, and my doctor wanted to do the BRCA testing, and the insurance didn't want to pay for it, even in 2018. And something amazing happened. The woman who was like the manager of that department, who made the decisions about whether you would get to have it or not, was Jewish. And I know it says Lisa Lewis on my screen. My name is actually Schloss Lewis, and I use that for medical. And she took it upon herself to call me up and ask me if I was Jewish and Ashkenazi Jewish, because they would have to pay, they would have to let me do the testing and pay for it. And I thought that was pretty amazing on her part, that she took the initiative to do that. And so I tested, unfortunately, fortunately, not unfortunately, fortunately, I do not have the BRCA gene. But I'm just curious, my father had prostate cancer. And should my daughter like still be tested for the BRCA gene? Is there still a chance? And my husband is not Jewish, but is there still a chance that she could have that gene if I don't?
So what I will say is, first of all, it's an amazing story, and it's one I relate a lot to, which is that you have these advocates, right, in places who are looking out for you. And I feel like a lot of good healthcare happens like that. You have a champion or someone that recognizes, you know, your situation. That happened a lot to myself and to my family. You know, as for the genetics part, you know, it is funny because I really am not a specialist in it's really my family history. But what I would say, Lisa, is I would definitely go to a genetics counselor and have a genetic counselor, you know, go through all of this with you, and you know, do family history. So that's what I would say. I think the world of genetic counseling, and I think that, you know, that would be something which would give you, you know, information enough to make that decision.
And where do you find a genetic counselor?
We have them at USC Norris, and so you can, you know, you can ask your oncologist or call them and ask for genetic counseling. I don't know if it's that easy as that, Bodor, but you know, you can talk with your oncologist and explain to them that you would like to have a genetics counseling session.
So in that session, I would discuss all of the things like that I had breast cancer, my father had prostate cancer, but I don't have the BRCA gene.
They'll go through a full family history with you. And it's, you know, it's very like, you know, visual kind of thing, and they'll walk you through the history, and genetic counselors can ascertain, you know, what your sort of risk level is and the extent to which you you may need to progress to actually being tested. So
Yeah, Lisa, I'm happy we have an excellent genetic counseling team at USC Norris, and I know the folks. Just email me and I'll get you connected to somebody who I think can guide you from there.
Okay, thank you.
Bob, you have a question.
Sure. Hi, I'm Bob Ritter from Ithaca, New York. And
Oh,
it was so interesting that my story is somewhat parallels yours. big Ashkenazi Jewish family. I even have relatives in Baltimore, maybe we're related, who knows. I was diagnosed with breast cancer at the age of 40 in 1996. And at that point in time, genetic testing, as you said, was not routine certainly in community hospitals. Through the years, I had assumed I was BRCA2.
Right.
My mom had pancreatic cancer, Ashkenazi young male. I fit the pattern, really, really well.
100%. Yeah, right.
Yeah. But then fast forward to about 5 years ago, I was diagnosed with prostate cancer. And at that point, we did go ahead and genetically test. I didn't have a BRCA mutation, but I do have a CHEK2 mutation, which is what they call, a lower penetrance gene that has less impact than BRCA.
Right.
But it's just so interesting to hear stories and sort of issues that come up, and it's so good to hear your story and to feel I very much relate to it. So thank you.
Yeah, no, thank you for that comment. And nowadays when one is genetically tested, it's not just for BRCA, it's often it's for a full, genetic panel, and we look at multiple. I mean, that's what's happened in my family. But yeah, back then it was really just the olden days of just taking forever to get test results back. And I mean, it was really the only thing that was being tested for in the population. But of course there are many different genetic familial syndromes that not just Ashkenazi Jews, I mean, we are predisposed to other things as well, but that it's routine, it's standard now, at least NCI designated cancer centers, that most people are going to get genetically tested with cancer. But yeah, I mean, your story is interesting because I would have sworn, like you, that you would be carrying a BRCA gene.
Yeah, I think it's a really interesting thing. I mean, there are some families out there who have a very strong family history of cancer and also don't have one of the known inherited, genetic mutations. And so it seems to me like that, if you have a strong family history, even without a known association to a gene, that you would still be in that high risk category. I mean, having a strong family history is still a risk factor, regardless of whether there is something known or not. Now, thankfully for cancers like, breast cancer and ovarian cancer and others, we do have those answers. And I remember reading about, how difficult that discovery came to be back in the 80s when Dr. Marie Claire was looking for the answer to genetic breast cancer. I need to find the movie that shows this. It's a fascinating story. It actually takes place in Toronto, Canada, because it talks about, a woman who had a very, very strong family history. There was still the genetic basis of cancer was not known, and actually it was ridiculed. It was actually flat out ridiculed by the medical community. And Marie Claire King was ridiculed. She was a woman doing cancer research in the 80s. Of course, the rest is history. We know how the story ends, but even not knowing that you have a specific genetic mutation, if you've looked and you can't find something, it actually doesn't mean that it isn't still something genetic. It just means that it hasn't quite been pinpointed. In addition to mutations, there are also other types of alterations that could contribute to cancer, like epigenetics. That whole world of sort of epigenetic predisposition to disease is very, very understudied. So I think it's good awareness for people to do the genetic counseling to understand like what we do know and have it mapped back to your family. But I think there needs to be more awareness just to still know that even if it's not any of those, but you have a strong family history, right? That there should still be a heightened sense of awareness and probably screening. And we still have to do better at a community to really help those people that don't have a known genetic mutation with still very strong genetic predisposition of some sort. But yeah, so I mean, like, for example, like the CHEK2 and the PALPI2, those things came later, right? It was was not known right off the bat. We have a question from Karen.
I just wanted to say thank you so much for telling your story. It was very moving, and I couldn't believe that you hadn't told it before because you told it so well. And I was diagnosed with breast cancer in January of 2020. And so, because of my diagnosis, I was permitted to have genetic testing, and they ran a full panel for like 20 different cancer genes, I believe. And so it was covered because of my diagnosis, but I'm in Madison, Wisconsin, and my insurance coverage is not the same one that's primarily at the University of Wisconsin, but the UW is where the cancer center is. So I just wanted to speak to coverage. You might have to go through your primary care provider and your local insurance if you don't have the insurance that is the primary one at the cancer center. So I got referred in for all my oncology because group health doesn't have any of that, any cancer treatment. But the counselor was excellent. I had a wonderful experience. We kind of geeked out on the science together because I have a biology background, though not a medical one. But I've often I've wondered because I don't have a medical background. I have a bachelor's in wildlife biology, but a lot of what helped me get through the whole cancer experience was how fascinating the biology was, and reading about what's happening in my cells and how does this happen, and what does this scan do and how does it work, and just the mechanics of what the risks are. And so I had really great care and had a great time learning as much as I could from all of my providers. But then I thought think how terrified patients must be that have no science education at all and no way of comprehending what's going on and thinking that somehow it's their fault that their cells mutated, not understanding that mutations happen every time cells divide. And so if you have more opportunities to get to tell your story, I'd really encourage you, even if it's at a Gilda's Club type cancer charity or somehow to the general public, to try to encourage screening for cancer. Because of my testing, my brother, who's 5 years younger than me, was able to get free testing. And so we both learned, unfortunately, I was 49 and he was 5 years younger, that we should have been starting colonoscopies at age 40 because we both have the CHEK2 mutation. So that left me terrified because I couldn't have a colonoscopy because my intestines were torn up from chemo. I had to wait another 6 months to heal. But he got one done right away and he had polyps removed. So, and when I was able to have mine, I was very fortunate, possibly due to being vegetarian, but maybe not. I didn't have any polyps, so that was a huge relief. So,
Right. No, well, thank you, first of all, for thanking me. It's it's funny, I don't tell my story just because I've never had occasion to do so, really, because I talk so much about I feel like in a weird way I've done what you've done, in the sense of you I'm not going to say it was as a coping thing, but genuinely fascinated and in a sense by what's happening to your own body because of your knowledge and your scientific expertise. It gives you insight, and I think that insight in a way can help reduce fear, and you understand the processes. I really relate to that. And so in a weird way, what I did was something similar, where I took a lot of experiences that I've had, but I just sort of applied it elsewhere. I decided that these all fed into I think early on I was terrified, but I was also fascinated by what was happening to my family. And I really enjoyed meeting the genetic counselor, and have always subsequently enjoyed my experiences in genetic counseling, and learning more and discovering more. My family, in terms of telling my story, I will say my family, who are BRCA positive, are very active and strong advocates. They often tell their story and are involved in a lot of genetic screening advocacy. The reason I didn't go in that direction, I don't know. I can't tell you the answer to that. It's like Batman. I don't know why he chose the bat persona. You know, I didn't, because I felt it was, you know, but yeah.
Yeah, because you get just focused on everybody and everything else you're doing, and your story. I mean, I could relate to that in a way. What you're saying is just, it becomes kind of like your own background noise in a way, even though it like takes up so much of you in another way. But when you're at work, that's not what you just don't make that connection for whatever reason. You take that, hat off. But I think this is part of the Bench with Bedside initiative. I just actually want to talk, this is actually part of the mission, is to connect the researchers with the patients and the participants, and to bring the human side out of the researchers, Kim. I mean, this was actually, you actually fulfilled our mission for us today by doing that, because it really is the essence. And Lisa, you've been around, you were one of the people, and Mary Alto, if she's still here, and Debbie, I see some familiar faces from the pre-COVID time when we started this. It was actually exactly about that. It was, building community and building connections. And so that the participants and the researchers, like, bring out the humanity in each other. Like, we see the human side in the participants, because well, actually, let me walk that back a little bit. We do see the human side, but as basic scientists in the lab, I don't know that like many basic scientists actually do. So it was to bring, the life to the test tube, right? And also for researchers to understand the people in the lab, we're humans, we have our stories, we have our struggles just the same. And this was part of what we wanted to do as part of the Bench with Bedside initiative. So thank you. And I just think it is so important for us to talk and about these things, and just continue to build community and build awareness. I do, before I ask for other questions and before we get too far along, also want to thank Audrey Sagayan, who is our project administrator for the Bench with Bedside initiative and the Eileen McGeever Breast Cancer Survivorship Program, and Dainara Ruiz, who is a graduate student helping us. Well, she's a graduate student in the Department of Public Health Sciences with one of the leading sort of scientists and community engagement experts, Dr. Lourdes Baez-Conde Garbanati. And she's, mutually being sort of coached by myself and Lourdes. And she's helping us really build up these webinar series. I just want to thank both of them for all the amount of work and effort that they put into the Bench with Bedside initiative and the breast cancer survivorship at Norris. So are there other questions? Either stories, comments, they don't have to be questions. They could be testimonies and comments and suggestions for us. Other questions for Dr. Miller? Lisa, is that a hand? I think I see a hand. Yeah.
I just wanted to mention one other thing. I just happened to have seen my oncologist yesterday, and she had several weeks ago, or actually a couple months ago, she had me do some kind of blood test now that tests if there's anything circulating. So
yeah, I can talk about that. Do you know what the name of the test is by any chance?
I can run and get the piece of paper, but I don't have it in front of me.
Does minimal residual disease sound familiar? Was it the Signatera test by any chance? Does that sound familiar to you?
No.
It's probably, if you use the word circulating, actually, that's probably what it is, but check and confirm.
Yeah.
But yes, this is now, so we moved from, actually, this is what our study is about. Our study is, we're developing a test to look for circulating DNA when women have completed treatment and are in survivorship. So we want to look for cells that sort of escape the current limits
Right.
of detection of imaging and things and other blood tests. There is one that has since come to life called, it's the Signatera test. It's used for breast cancer and colon cancer. There's a lot of other people developing these tests. We're actually at Norris, we're actually doing the same thing. But yes, it is sort of now, instead of early detection of breast cancer, it's also, in a way, you could think of it as early detection of recurrence, in the sense that if there are still tissue cells in the body after treatment, even years after treatment, then you want to catch that before it becomes visible in a scan. So
Fortunately,
that's the goal. So yeah, so
it was
absolutely.
negative, fortunately. So
Oh, thank God for that. That's great news. That's great news. But yeah, minimal residual disease or molecular residual disease, those are the new buzzwords in the solid tumor space. It's very an active field in breast cancer. The hem-onc people, so all the liquid tumors like, myeloma and leukemia, they've been doing this as part of their standard of care for many, many years now. It's only starting to happen in the solid tumor space as of late. Yeah, so congratulations on that. It's actually really good news that it's negative.
thank you. When I email you, I'll tell you the name of it. Yeah.
Yeah, please do, just to confirm. Just I'm just guessing that that's probably what it was. Any other questions or comments? Well, as usual, and as always, thank you all for coming. And again, this is going to be, it has been recorded, so it's going to go up on our website for anybody to rewatch and for others to go back to and watch if they weren't able to make it. But again, I want to thank you for taking, again, your Saturday morning to be here with us today, even especially on a long weekend. Special thanks to Dr. Kim Miller for joining us and sharing with us your fascinating story and journey, and how you showed us, even if you hadn't really done it before, how you beautifully kind of merged your lives, like your personal life and story with your work. It's so important, and it's so valuable to everybody listening, but to also the scientists who are doing this, to just remind ourselves that we're human at the end of the day. And we have our own stories, and it's important to share them. So thank you for your generosity on that. And we'll probably ask you to come back and do it again in
course.
the future. We would love
Yeah.
to have you come
Well,
back.
thank you all for having me and inviting me and spending a Saturday morning with me, and for allowing me to tell my story and to actually make that connection really for the first time in my adult life. It was really an incredible opportunity for me to be able to do that. So I am grateful to all of you for listening.
Thank you. Thank you, everybody. And have a great rest of your weekend, everybody. And we hope to see you again next month. I think next month we have a plan, right? Audrey and Dianara, we're going to have a panel discussion. So please come back. And the panel discussion is going to be about people, both scientists who've had cancer and other community member and advocates who've had cancer, basically talk about their experiences. And Dianara and Audrey are going to be moderating that session, and we'll give you more information about it in the coming weeks. We hope to see you next month. And thanks again, and have a great rest of your day and weekend. Bye, everybody.
Thank you.
Thank you. Bye.